uterus from middle layer of uterus. And this thing, just you have to remember this also, this is a junctional zone. We will see this junctional zone during our adenomyosis session. So now I think you must be knowing this whole is myometrium. Myometrium has 3 layers, outer layer, middle layer and inner layer. Outer and middle layer are separated by the arcuate vessels. All this, there is just like IETA and IOTA, we are also having MUSA, that is morphological uterus sonographic assessment. Morphological uterus sonographic assessment for all myometrial pathology in order to do the definitions, measurements, and how the echogenicity or shadowing, everything we have to do under MUSA consensus statement. So this is uterine measurement. See, last time we had studied uterine measurement and we had taken the measurement from the length of the uterus from this portion. This is the fundus, this is the cervix. We had taken total and we were saying that even tracing method will be good because cervix is a bit bent position. But according to MUSA consensus statement, the length of the uterus is first is corpus length, that is D1. This was our question also. D1 is the corpus length. Now, what do you mean by corpus length? We have to measure the length, distance between this serosa and the fundal point of the uterine cavity. This is the uterine cavity, this one. This is the fundal point of uterine cavity. So the distance between serosa and the fundal point of uterine cavity plus the uterine cavity length from fundal tip up to the internal os. This whole length A plus B will show corpus length. The anterior-posterior length is same measured as otherwise. We are measuring from anterior to posterior. You can take it in the transverse measurement also, or you can calculate it, measure it in the sagittal plane also. And the corpus width or D3 has to be taken in the transverse scanning. And I had told by transverse scanning, I mean the probe marker will be towards 9 o'clock position. So that I have done the transverse A, and the widest portion will be taken for, just like endometrium, you have to take the widest portion, the widest endometrial canal, then you don't have to do here and there for measuring anterior and posterior. In the same image, you have to measure anterior as well as posterior length of the myometrium. Because so many times there is asymmetry of anterior and posterior layer, but in the same image, we have to calculate it. The cervical length has to be calculated separately. So MUSA consensus statement says that the corpus length is this length A plus B, corpus height is this, and corpus width is this. And we have to add cervical length in order to find out the total length of the uterus. Now, I have to tell something about FIGO, palm and coin method also. FIGO, as you know, is International Federation for Gynecologists and Obstetricians, and they have derived this palm and coin method. Now, and it has been written by Munro. It's not shown in this. So the palm and coin method is P is of polyp. P signifies this is all abnormal uterine bleeding. What are the causes of abnormal uterine bleeding? You should remember as palm and coin system. P is polyp, A is adenomyosis, L is leiomyomata, and M is malignancy and hyperplasia. Leiomyomata will consist of many, like submucosal and many others also that we will be studying in the coming session. The coin method system is C is coagulopathy, O is ovulatory dysfunction, E is endometrial reasons, I is iatrogenic. For example, so many times we are giving hormones and all, that also causes abnormal uterine bleeding. And then some are not yet classified. And then we have to write down like this. If there are polyps, you have to, if there are leiomyomas, fibroids, then below L you have to write whether it is submucosal or subserosal or intramural, you have to write, and all others will be 0. If there is a case of adenomyosis, then we will write A1 and all others will be 0. In case of polyp, see, I have written P1, all others 0. In case of endometrial hyperplasia, see, all these are 0, but there is 1. So this is palm and coin method, but palm and coin method also suggests ultrasound, but there is no standardization. So no standardization means it is not coming under the Musa-Consensus statement. So let us start with our myometrial pathologies. There are many pathologies that come under myometrium. According to Musa, we are seeing some very common pathologies. These are leiomyoma, we call it as fibroid, leioma or myoma, everything. All these 4 terminology for the same. Second is adenomyosis, and some rare are calcifications, enhanced myometrial vascularity, congenital anomalies we had seen last time also, RPOC, arteriovenous malformation we had seen last time, and cesarean scar pregnancy. So now let us come to the most important, most common pathology we also see in our outdoor, and that is myoma. Myoma are the benign tumors of the smooth muscle, and see this.
There was a question on this question.
Question number 1. We had given the number 1A. This is all. See, this thing is very. This figure is looking so complicated, but it is not so. When I tell you, you will feel it's so easy. We can divide all these type of tumors into 3 groups. This one within the endometrial cavity will be known as submucous myoma, because they are having something introduced into the endometrial cavity. These green color ones will be intramural, because what I mean by intramural is they are in the myometrium. And the blue color, that is 5, 6, and 7, they are going towards serosal cavity or peritoneal cavity. Therefore, they will be known as subserosal. Now, let me tell you, number 1, this 0, 1, 2, even we had studied in the endometrial session. 0 is when it is pedunculated. The whole myometrial tumor is within the endometrial cavity, nothing inside the ear. Only the stalk, it is attached to the myometrium. The whole tumor is within the endometrial cavity. So it is number 0. Number 1 is, see, now it is attached to the myometrium. All are from myometrium. We have to remember this, all are from the myometrium. But in 0, it is attached by a small pedunculated stalk. But in case of number 1, it is attached by a very broad stalk. This tumor is, see, it is less than 50% intramural. It is more in the endometrial cavity and very less in the myometrium. So this will be called as number 1. It is less than 50% intramural. Number 2 is when it is more intramural, less in the endometrial cavity. So see, it is more 50% intramural and less in the endometrial cavity. So 0, 1, 2 are submucous type of myometrium. 0 is totally inside the endometrial cavity. 1 is more than 50% in the endometrial cavity, and 2 is less than 50% in the endometrial cavity. Now coming to number 3 and 4. See, this 3 is both are intramural. Intramural means within the myometrium. But in number 3, the portion is just near the endometrium. So it is known as endometrial, intramural number 3, and this portion is within the myometrium totally, not this endometrium, neither in endometrium nor in the serosal cavity. So it is within the myometrium, and so it is named as number 4. Number 4 is the most common type of myoma we see commonly. So 3 and 4 are intramural myomas. 3 and 4 intramural myomas. Now comes number 5. 5, 6, 7 are subserosal. See, 5, 6, 7. Now, number 5 is when the subserosal is more than 50% intramural. See, all are how much it is in the myometrium, that is what is important. So number 5 is when more than 50% are in the myometrium. Number 6 is less than 50% in the myometrium. So more is in the serosal cavity. See, it is more projecting into the serosal cavity. And number 7 is totally in the serosal cavity attached by a peduncle to the myometrium. So now again we will see number 0 is in the endometrial cavity. Number 7 is in the serosal cavity. You should remember this. Number 0 is in the endometrial cavity. Number 7 is in the serosal cavity. Number 1 is less than 50% intramural. And number 6 is again less than 50% intramural. Both are, see, this is from this side and from that side. 0 is in the endometrial cavity. 7 is outside in the serosal cavity. Number 6 is less than 50% intramural. This is less. So it is 0. What is 6 is as 5. What is 5 is as 2. And 3 and 4 are totally intramural. So 0, 1 and 2 are, we can write down during reporting. If we have any difficulty, we can write down 0, 1, 2 as submucous myoma, 3 and 4 as intramural myoma, 5, 6 and 7 as subserosal myoma. There is another variety, that is number 8. Number 8 signifies our cervical myoma, broad ligament myoma or parasitic myoma. That cases, they are very few in number, but still they have classified it as number 8. Now, another important point is hybrid leiomyoma. They also say it as pan-leiomyoma or global leiomyoma. That shows the leiomyoma is having inner side towards endometrial cavity and outer part towards serosal cavity. And 2 and 5 signifies that it is from 2 till 5. 2 to 5. This 2 to 5 means the extension is from number 2 of the classification up to the 5 of the classification. So 2 and 5 is a hybrid type of myoma. So I think this figure is very important, but now it must have become easy for you all that 0, 1, 2 are subcutaneous endometrial mucus. Number 3 and 4 are intramural. Number 5, 6 and 7 are subserous myoma. So now let us see different types of myoma, what we see during the live image. So this is a submucous myoma. See, the submucous, this is the endometrial canal. The submucous myoma, it disorders or the endometrial canal. So endometrial canal becomes disordered. And if it becomes disordered, there is chances of infertility, there is chances of abortion, premature birth, or so many things can occur in this type of submucous myoma. Secondly, see, the submucous myoma is having this, we will study again. This is another submucous myoma with vascularity shown by the circumferential vascularity. We will read again in the next slides. This is a type of intramural myoma. See, this is the endometrium, this is the serosal covering, and this is totally within the myoma, within the myometrium. So this is what type of myoma? So I will show you. See, this is number 4 because it is not in connection with any endometrium. So it is number 4 myoma, type of myoma. So we had a question number 1 myoma. So number 1 myoma was 50% intramural. So this is intramural myoma. This is endometrium and this is serosa. This is what this one is, urinary bladder. See, multiple myomas are there, but this one is a subserosal myoma. See, it is projected towards the urinary bladder. So this is subserosal myoma. This one is a calcified myoma, although it is intramural, totally covered by calcification or Wormstell eggshell appearance of calcifications. So when we see a myoma, we have to write down the image, the number of myomas, because normally it is not a single entity, it comes in multiple number. We have to write down the location of myoma. Location of myoma can be written both as like submucous, intramural, and subserous. But there is another type of side seeing, that is anterior or posterior, towards right or towards left side. If you see in the transverse image, you can see whether the myoma is towards right side or towards left side. So whenever sometimes when there is multiple myoma and the gynecologist surgeon sends you for the images here, you have to show in diagram also how to do fibroid mapping. In the fibroid mapping, you have to write down, you have to first draw a diagram of
Dr. Ranjana,
uterus.
is your slide moving? Is your slide moving or not?
No, sir, because I am talking about fibroid mapping and I have not included fibroid mapping in this.
Now it is okay. Now.
So, sir, I am audible now, sir.
Right, yeah, you are audible.
So, fibroid mapping, we have to draw the diagram of uterus longitudinal as well as transverse scan in the diagram by pencil or pen, and you have to write down for the myoma locations, either anterior, posterior, right, left, submucous, serosal, or intramural. Everything you have to write down in the fibroid mapping. Now, so when we come to the common pathology of myoma, we have to describe it in many types, in many categories, which are written in the MUSA, that is morphological uterus sonographic assessment. First is echogenicity, second is shadowing, and third is vascularity. When I talk about echogenicity, even last time I had told, echogenicity is the structure, ecotexture, how the sound waves are traveling through it or not. See, this one, although it is slightly different, they have made it totally black, but it is hypoechoic, slightly much more lighter than this one. So this is anechoic. Anechoic means it is anechoic like structure, but they have shown this one as hypoechoic. Now, what do you mean by hypoechoic? This color is slightly lighter than outside color. Means we have to compare any structure, any SOL in the uterus with the other surrounding structure or echogenicity. When the echogenicity of the myoma, this myoma is lower, darker than the surrounding structure, that time it is known as hypoechoic. When it is similar as the outside surrounding myometrium, then it is known as isoechoic. See, but isoechoic myomas are very, very difficult to find out unless they have some pathology, degeneration, calcification, or by vascularity, we will be able to know, because the ecotexture will be similar as the surrounding ecotexture. And hyperechoic is the lighter part. See, this is darker part and this is lighter than the surrounding myometrium. Now, if I say uniform, uniform means it is homogeneous. Homogeneous means totally it will look similar. This part and this part will look similar. So this is uniform. This one is uniform. This we will also see in the live fibroid images. So these are three types of uniform myomas: hypoechoic, hypoechogenic, isoechogenic, and hyperechogenic. Now come to the non-uniform. Non-uniform means heterogeneous, in which this part and this part will not look similar. So non-uniform again is divided into having three categories. First is mixed echogenicity. In the mixed echogenicity, see, you are seeing hyperechoic elements as well as hypoechoic elements. In the echogenic area, see, this one is a hypoechoic non-uniform myoma having some echogenic spots within it. See, there are echogenic spots within it. This one is a hypoechoic non-uniform hyperechoic. This is a hyperechoic non-uniform myoma with some degeneration, the cystic or hyaline degeneration areas within it. So all the myoma's ecogenicity is divided into uniform, non-uniform. Uniform is again having three categories: hypo, iso, and hyperechogenic. Whereas non-uniform is having three categories: mixed ecogenicity, ecogenic areas, and cystic with cystic areas. So this is a real-time images. So example of uniform hypoecogenicity. This is the surrounding myometrium. It looks lighter, and this myoma looks darker than this. So darker means it is hypoechoic. Similar means it is isoechoic. More ecogenicity means it is hyperechoic. So this one is lighter. So this is hypoechogenic. This one is, see, it is so difficult. This one is similar to the myometrium surrounding it. So this is isoechoic or isoechogenic. And this one is lighter than the myometrium around it. So this is known as hyperechogenic uniform myomas. Now let us read the non-uniform myomas. Non-uniform myomas, this one is mixed ecogenicity. See, this is hypoechoic area and this is hyperechogenic area. So this is consisting of non-uniform. It's a heterogeneous mass, inhomogeneous. See, having hypoechoic as well as hyperechoic. And in this case, not many ecogenic foci are seen. Maybe it is because of calcifications. More of ecogenic foci seen within the myoma. So it is non-uniform ecogenic areas. And see over here, there is maybe it is cystic degeneration, and there are many types of degenerations in the myoma. And the degeneration occurs because, see, this always myoma is having a centripetal growth. The myoma increases in size from the inside. So the vascular supply in the outer part, it outflows, means the supply decreases. And when the supply decreases, degeneration occurs. It may be hyaline degeneration is the most common degeneration. Then it becomes cystic degeneration. It may be myxomatous, lipomatous. It may be calcific degeneration. There are many types. And lastly, last but not the least is sarcomatous degeneration. So these are with the cystic area. See, this is so non-uniform is having mixed ecogenicity with ecogenic foci, ecogenic areas, and this is with the cystic areas. But so many times when we look at these images, we get confused. So anytime if we are getting confused with the growth of the fibroid or its ecogenicity, we should refer the case in the atypical feature with atypical features. So that was about ecogenicity. Now next is shadowing. All the myomas are hard structures. As we see, when we take out the myoma, they are so hard. So all the myomas, we should remember that the myoma, this is the outer line of the myoma. The outer line of myoma is a pseudo capsule. It's not a true capsule. It's a pseudo capsule. What do you mean by pseudo capsule? When it increases in size and centripetally, it is compressing the smooth myometrial fibers around it, and that forms the pseudo capsule around it. See, this is a pseudo capsule around it. So it causes not many types of calcifications. We are categorizing them into three groups. This one is a linear shadowing from the edges. See, this is an edge, it is causing. See this one. This is the myoma and it is causing linear edge shadowing. The second one is the fan-shaped shadowing. It is coming from the total area. See, these are some calcific points and it is causing so many fan-shaped shadowing from it. See, you see in this real-time image, so many, what do you mean by fan-shaped shadowing? There will be this darker area alternating with lighter area, darker area alternating with lighter area. Depending on the ecogenicity, depending on the type of smooth muscle, connective tissue, everything is there in the myometrium, smooth muscle as well as the connective tissue. Different type of reflection and refraction occurs from those tissues causing fan type of shadowing. And third is a block shadowing. See,
just
this
wait,
rope is,
Ranjana, just one 1 minute, please. This middle picture, please everybody note that you can see slightly echogenic shadows on both sides. This is an artifact. It is called a side lobe artifact. On the side of the myoma, if you see these lighter areas, it is called a side lobe artifact.
These
Actually,
are the side
the
lobe artifacts.
myometrium is not echogenic at that point, but because all the sound waves are attenuated here, these two echogenic areas are called side lobe artifact. Beautifully brought out in this middle picture.
Madam, just one moment. Side lobe is this one, number one. Number one is the side lobe. Number two
Yes, sir.
is because of the echogenicity.
Yes.
Why this is echo? Because it is echogenic. It is not allowing the sound to pass through. That is why the shadowing lines are there. These lines are there. So
These lines.
this hyperechoic region, it is reflecting all the sounds 100%, and nothing is allowed behind this. Therefore, this is
Whatever
called
sound wave is going
again.
there, because all the sound waves are attenuated to very closely, that is why it is appearing little
It's a fan
echogenic.
sepet. Number two is fan sepet.
Fan
Number
sepet.
two is fan sepet, and number one is the side lobe
Edge shadows.
Edge shadows. Again.
That is
So
edge
one thing again,
artifact.
edge
Edge
artifact.
artifact.
So one thing again I want to tell you, the shadowing. What do you mean by shadow? Shadow means the way the rays sit. This is a calcification. This is a calcified myoma, eggshell calcification. Nothing is going behind it. So we are not able to see anything over here. This is known as shadowing. See, we are saying this portion, it becomes so difficult to see. This is shadowing. What is attenuation? Attenuation, some rays are passing. Some rays are passing. So this is also attenuation. This is total shadowing. This is slightly attenuated. Normally in retroverted uterus, because when we see in the transabdominal scan, see, when we see in the transabdominal scan, retroverted uterus, the fundus portion is obscured by the rays going from the endometrial canal and all. And that time we are not able to see the fundal portion, and we think it to be a case of myoma. That is attenuation. Another one is enhancement. Enhancement is like cyst. Whenever there is a cyst, you will see, I will show you myometrial cyst, you will see white color area just behind it because all the rays are passing through it. So there are different terms in cases of ultrasound, and this is shadowing. This is slightly shadowing with attenuation. This is total shadowing. So this is calcific or eggshell shadowing, block shadow, which is we are not able to see anything behind it. So now each and every SOL in myometrium, we have to write down the vascularity also. So before going into that, we should study the normal vascularity in the myometrium. As I told you, I had shown you the arcuate vessels in between middle and the outer port. The arcuate vessel is a branch of just arising from the ascending branch of uterine artery. You know, uterine artery is coming from the anterior branch division of the internal iliac artery. See, the arcuate artery is going parallelly. It is going through the whole diameter of our uterus. From the arcuate artery, so this is arcuate artery. You see, it is going throughout such a big fat artery going throughout the between outer and middle layer of the myometrium. From there, radial arteries get originated and they go perpendicularly. See, these are the perpendicular arteries, the radial arteries, and they go till the basal part. In the basal part, it becomes basal artery, and then in the endometrium, it becomes spiral arteries, which we had studied last time. So see over here, and this is the longitudinal scan, this is the transverse scan. See, in the transverse scan also, this whole is outside is the arcuate artery. The branches which are going towards endometrium is the radial arteries. So what are these? These are the radial arteries. See, this is outside is the arcuate artery, and in between, just opposed to the endometrium is the basal artery, is the radial artery. So we should remember arcuate artery is outside and the basal radial artery is inside the inner coat, middle and inner coat of the myometrium. So now we can understand the vascularity of myoma. There are two types of vascularity in the myoma. First is circumferential vascularity. Second is intralesional vascularity. Now, what do you mean by circumferential? See, circumferentially, you are getting a vascularity within the myoma. In this case of intralesional vascularity, see, so many vessels you can see within the myoma. So this is a circumferential vascularity. See, this is the wall of the myoma and you are getting circumferential, but inside also you are getting a bit that is intralesional. So two types of vascularity seen in myoma. One is circumferential, another is intralesional. See, just like IETA, IOTA, we have to describe the vascularity of any lesion in scoring system. And we know, as we had learned last time, that there are four types of scoring: score 1, score 2, score 3, and score 4. Score 1 means no vascularity. See, nothing doing. And you have to write separately for circumferential vascularity as well as intralesional vascularity. So score 1 means no vascularity, no, nothing. See, you are not seeing any type of vascularity. Score 2 is minimal vascularity. See, in the edges you can see a bit of blood vessels. In the intralesional variety, you can see a bit of vein. In score 3, you are seeing moderate type of vascularity. See, this vascularity is much more than this, but lower than this. So it is moderate type of vascularity. It is score 3. You are getting moderate type of vascularity. And score 4 is abundant or strong vascularity. Total lesion is vascular. See, so score 1 is no vascularity. Score 2 is minimal vascularity. Score 3 is moderate vascularity. And score 4 is abundant or strong vascularity. This image is also in the one cervical fibroid. We will read it in our next video. This is again intramural myoma. We will see in our video. And this one, see, it's so difficult. This is a uterus, which anteverted uterus, seen so much nicely, but this is the isoechoic myoma. See, it is just like myoma, just like the surrounding structure. It is very, very difficult to find out such type of myomas. But when you put vascularity, it will give circumferential or intralesional vascularity, which will make you think, oh, this is a case of myoma. I was going to miss it. So this is all about myoma. So we read myoma as number of myoma, wherever it is there. Second is location of myoma, anterior, posterior. Third is site of myoma, submucous, intramural or subserosal. Then we studied about the echogenicity of myoma, the shadowing of myoma, and the vascularity of myoma. Now let us, myoma is maximum found cases in the OPDs coming up at least 30%, 25 to 30%. Next one is adenomyosis. This also is very common. About 20% of cases of the abnormal bleeding is because of adenomyosis. So what do you mean by adenomyosis? Adenomyosis means abnormal presence of myometrium, endometrial tissue within the myoma. See, this figure is of uterus. You are seeing the serosal layer. This one is the serosa. This one is the endometrium. See, the red orange color layer, this whole is endometrium. This is fundus, this is body, and this is corpus, and this is cervix. And this whole is myometrium. See, this one is myometrium, this is myometrium, this is myometrium. When the endometrial tissue from the endometrium goes into myometrium, gets implanted into myometrium, that time we call it is a case of adenomyosis. So abnormal presence of endometrial tissue within the myometrium is known as adenomyosis. And another point is when it occurs, when this endometrial tissue goes in other places, then it is known as endometriosis. This is adenomyosis. Outside is endometriosis. We will read a bit about endometriosis also. So how will we know that this is a case of adenomyosis? Again, like myoma, there are 4 important points to differentiate. One is the uterus becomes enlarged, because this is there. Although there is endometrial deposits over here, the myometrium surrounding it undergoes hyperplasia. So it becomes increased, enlarged. See, this hole is enlarged. The enlargement may be 2 types. One is asymmetrical enlargement. What do you mean by asymmetrical enlargement? See, this anterior posterior diameter of anterior part of the myometrium is slightly lesser, and this posterior myometrium is great. So maybe the adenomyosis is affecting the posterior. Commonly, adenomyosis affects the posterior part of the myometrium. So this is, you have to write down differently, separately, the thickness of anterior and posterior myometrium thickness. Second is globally enlarged myometrium. Now, what do you mean by globally enlarged? The whole uterine cavity, the myometrium of the whole uterus is affected by adenomyosis. So it becomes enlarged in size. Anterior-posterior diameter of anterior, posterior, fundus, everything is thickened. So that is known as globally enlarged. We will also see in the live images. Second is fan-shaped shadowing. Now, what do you mean by fan-shaped shadowing? See, it is subendometrial linear striations. It will do all the muscular hypertrophy from muscle, everything. It is connective tissue. We are having lot of fan-shaped shadowing. Third is myometrial cysts, small black colored points. See, surrounded by the white rim. See, you can see black points, dots surrounded by white rings. You can see in the area of adenomyosis. So this is myometrial cyst. Then comes poorly defined endometrial myometrial border. This is very, very important. I had shown in the last figure how the junctional myometrium is seen, and it is so thin, hypoechoic, and you can separate, you can differentiate the endometrium from myometrium. But in cases of adenomyosis, sometimes it gets full, the whole portion is suffering from adenomyosis. So it becomes thickened. See, in this case, it is disrupted. So there is poorly defined endometrial myometrial border. So first is enlarged uterus, fan-shaped shadowing, myometrial cyst, and poorly defined endomyometrial border. So now we will see in our live images. Enlarge my uterus. So first I had told, see, this is the anterior myometrium, this is the endometrium, this is the sagittal scan of uterus, this is the urinary bladder, this is uterus, endometrial cavity extending into the cervix. Now we see the anterior myometrium and the posterior myometrium. So much difference. This posterior myometrium is so thickened in comparison to the anterior myometrium. So this is known as asymmetrical thickening, and we have to write down the measurement of anterior and posterior separately. This is a case of globally enlarged uterus. See, all of the endometrial cavity is till this point, and this is fundus. So it is globally enlarged. The anterior myometrium is thickened, posterior myometrium is thickened, and the fundus is too much thickened with so much of the fan-shaped shadowing also. So this is asymmetrical thickening. This is globally enlarged uterus. Second comes the shadowing. This is fan-shaped shadowing or subendometrial linear shadowing, acoustic striations produces this type of shadowing, and they also call it as rain in forest. See, there is white color, this white color alternating with the black color. So they say it appears like rain in the forest. But this is the fan-shaped shadowing we are getting because of the linear striations. Now these are the myometrial cysts. Whenever we see a myometrial cyst in myometrium, it should make us think that maybe it's a case of adenomyosis. Now what do you mean by a myometrial cyst? These are small anechoic or black dots. These are black dots surrounded by a white rim. What are they? They are the dilated endometrial glands. And this is with the menstrual blood, because see, in adenomyosis, the endometrial tissue is in the myometrium. So whatever hormone disturbance occurs in the body, disturbance, you can say whatever the cyclical hormone changes occur in the body, it will also be seen in the adenomyotic structure. So whenever there is menstruation, this will also produce some blood within it. So these are myometrial glands, dilated myometrial glands with menstrual blood within it. See, and as I was telling, there is enhancement. See, this is known as enhancement. So we had seen shadowing, we saw enhancement, and we also saw the attenuation behind the structure. So these are the myometrial cysts. Mostly it occurs near the endometrium, but it may be deep also. This is known as superficial adenomyosis. This is a deep adenomyosis. Now comes poorly defined endometrial myometrial border. This is very, very important in the endometrium. See, otherwise we should have got a clear margins of endometrium surrounding the just adjacent to the myometrium. But in this case, so poorly disordered arrangement. Along with these are echogenic focus within the endometrium. These are echogenic focus. This one. This one is a endometrial bud or endometrial island. What do you mean by endometrial island? Some endometrial tissue, when it is getting detached from the endometrium and comes into the myometrium, that time it is known as endometrial island, because it is made up of endometrial tissue. It will also undergo menstruation as hormonal changes occur in the body. This one is, these are the endometrial lines and endometrial bud. We will read about it in our next video. This is endometrial lines. Endometrial lines are coming straight from the endometrium. And these are the endometrial buds, which are again coming from the endometrium and coming inside. How can you find? So many times this is so difficult to find, say. But when we have cysts, SIS means saline infusions sonography. When we are putting saline, these lesions we can easily see because the saline gets introduced into these are the endometrial cracks. These are the endometrial myometrial cracks. The saline will introduce, and this will look as lollipop diverticulums. This will look as lollipop diverticulum. These are the endometrial myometrial cracks. So we have seen 4 types of myometrial pathology category within adenomyosis. First is we are seeing all the asymmetrical or globally enlarged uterus. Second is we are seeing the fan-shaped shadowing. And third, we are seeing the myometrial cyst. And fourth is poorly defined myometrial endometrial border. So these 4 things, if we find out, it comes in mind that this may be a case of adenomyosis. So now I'll show you some more examples. This is the superficial adenomyosis. See, this is the endometrium, and the myometrial cyst is just near the endometrium. So this is superficial type of adenomyosis. This one is superficial adenomyosis. You are seeing the endometrial cavity and the myometrial cyst are just near the endometrium. So and causing enhancement. As I told, this is the enhancement. Now this is a type of deep endometriosis. See, now the endometrium is this, and we are going behind. See, this is the endometrium, and we are behind. So this is a deep adenomyosis. So the adenomyosis, 2 out of 6 criteria if present, we can assign it to be a case of adenomyosis. One is wall thickness asymmetry, that is anterior myometrial thickness and posterior myometrial thickness. If the comparison is more than 1.5 times, then it is one criteria for adenomyosis. Heterogeneous myometrium, because you will find hypoechoic, hyperechoic, cystic area, so it is heterogeneous myometrium. Poor endometrial myometrial transition zone, fan-shaped shadowing, and question mark sign that I will tell you in this, and translesional vascularity that we will read again in the next few slides. So what do you mean by this? Nowadays, this question mark sign, they are giving it a lot of importance. See, this is ear, S or question mark sign. See, this is question mark sign. See, this one is a question sign. But it is not included in MUSA. MUSA is morphological, uterus, sonographic assessment. So this, as it is associated with deep infiltrating adenomyosis, therefore it is not included in the MUSA consensus statement, because it is included in the endometriosis. But still, we should know what is question mark sign. See, this case, just you see, this is a uterus, transvaginal scanning. We are saying this is a uterus. Huh? This one is, see, I think you can see this, my arrow. This is the anterior wall, this is the posterior wall, and this is the cervical portion. As Madam Pramodini Madam had told in the first basic chapters, the meaning of anteverted and retrograde, anteflexed and retroflexed. V is for vagina. So anteverted is when this whole uterus over the vagina, the thing, it is coming anteriorly, then it is anteverted. Retrograde is when the whole of uterus over vagina is towards posterior, that is retrograde. Now, what do you mean by anteflexed and retroflexed? Just it is the configuration between cervix and uterine body. See, this one is retroflexed. See, this, the whole fundus, it has gone posteriorly. So our cervix is anterior, but this one is posterior. Now you can see cervix is just anterior near the urinary bladder, but the fundus is just posterior and just near the rectum. So this is giving a question mark sign. This endometrial cavity is looking, uterus body is looking up, and the question mark sign, because the anterior portion of the cervix is towards endometrial cavity. It is anteverted uterus, but retroflexed, because the flexion is, see, this is flexion. You can see a nick. If there is a retroflexion, you can see this nick between this cervix and the fundus. So it is when the question mark sign is found, it is a case of anteverted but retroflexed uterus. And if it is retroflexed uterus, it must be due to some adhesion or something. So this is known as question mark sign, and it is gives 75% sensitivity and 93% specificity. So till now it has not come, but I think in near future we may be having question mark sign included in our MUSA consensus statement. So now let us come to some rare myometrial pathology. Many of them are there. So we will study. First one is myometrial calcifications. So this was one of our question was also there. In postmenopausal cases, postmenopausal ladies, when we do ultrasound, so many times we are seeing there are some echogenic spots. This is endometrium. See, this is endometrium, this one. Huh? And we are seeing echogenic spots around the uterus musculature, myometrium. These are nothing but arcuate artery. See, I had shown you arcuate artery separating the outer cord and the middle cord. This is the arcuate artery blocked. As postmenopausal cases, we are not, the uterus now it is of no use, so they get blocked with calcifications. Therefore, the arcuate artery gets blocked with the calcification and we get this type of view in the ear. So it is physiological. It is never a pathological finding. So many times we get this in the postmenopausal case. See, this is in the sagittal. This is a transverse plane. This is the endometrium, and we are getting the calcific points of the arcuate artery. These are the calcific points of the arcuate artery, blocked arcuate arteries. So many times in cases of atherosclerosis, arteriosclerosis, see, the artery becomes so much calcified. The calcium deposit occurs within the vessel wall, and then it looks as if this is a case of pyometra. This whole looks black, and this is. So one has to be very, very careful in order to do the ultrasound scanning of these cases. This is arteriosclerosis, arcuate vessels, arteriosclerosis in the transverse scan, and this one is the endometrium. Now we will read the retained products of conception. This we had studied last class also. So as we know, see, this is this is radial vessels. These are the arcuate vessels just near the serosa, and these are the radial vessels. This is a common case. This is a normal pathology, normal myometrium with radial artery vasculature. In this case, so many times we get retained products of conception, which is written as contents in the endometrial cavity with mixed echogenicity. And that time when we put our Doppler, we see lot of Doppler color flow within it. If there is a color flow, then we think, yeah, it's a case of RPOC, because RPOC is the tissue which is getting connected with the endometrium of the endometrial cavity. But so many times this is a case of endometrial RPOC. But so many times we can also get enhanced myometrial vascularity due to arteriovenous fistula. So we have to differentiate RPOC from arteriovenous fistula. In arteriovenous fistula, because there is absence of capillaries between arteries and veins, we get lot of orange color, lot of flow within it, high velocity blood flow with low impedance. High velocity blood flow, they also say that if DSP is more than 40 centimeter per second, we can confirm it as a case of arteriovenous fistula, because
I think, Ranjana madam, you got disconnected or what? Your screen is no more to be seen. Ranjana madam. Ranjana madam, can you hear me?
Yes, she got disconnected. She's coming.
She will rejoin. I just
joining.
called her. तांकु phone करी के कही छी
She's trying. So while she's trying, Hasmukh sir, please tell us the importance of arteriovenous.
Yeah, AV malformation is a pathology
Dangerous.
where we will not see any ecogenic endometrium normally, because they are completely vascular, and we will show some the velocities of the waveform will be higher. So because it is a malformation, because the arteries are having high velocity and the veins are distended. So when arterial venous connections, we will always get a high velocity flow. So this is very, very abnormal and very significant to detect.
Dangerous also.
The significance
never
is
do diagnostic ureterics in that case.
In such a case, because the patient will bleed.
To death.
Yeah. So that is the importance of AV malformation.
She's joining. She got disconnected. She's trying to join. Sambit, in the meantime, can you share screen?
Hello.
Yes, now you can share screen once more.
Screen share. This one. So last one.
No. From
This
RPOC.
one I had shown. So this is RPOC, and we are seeing the increased vascular supply in the basal part of the myometrium. So RPOC is over here. The radial arteries in the basal part of the myometrium gets increased vascular supply in order to give it the vascular supply. So now coming to the congenital anomalies. See, as we had this slide also we had seen last time. In the congenital anomalies, see, this is the uterus in the broad, the transverse measurement of the uterus increases in centimeter. This one is the transverse. We normally know it is normally 4 to 5 centimeter, but it increases in the dimension. And then if we do just below it, if we do the scanning at the time of secretory phase, we can easily see two canals in the this portion, one canal, and this portion another canal. But even then we may think that it is total endometrial cavity, but there will be a layer of myometrium in between endometrial cavities, which we can see by putting Doppler. In the Doppler we will see the radial arteries going through it. So these are two, it may be, so, but we cannot tell whether it's a case of didelphys or bicarbonate or septate unless we do 3D or MRI. But we can know that there is congenital anomaly with two endometrial cavities over there. And there is myometrial vascularity within this portion. Now, this is a case of normal cervix. See, this is a case of two duplication of the cervix in a bicarbonate bicolis. See, you can see two cervix over here. So, this is a case of bicolis bicarbonate. This also we had seen last time. It's a case of imperforate hymen. So, transabdominal, see, you cannot do transvaginal in imperforate hymen, but you can do translabial. I want to show translabial ultrasound. Maybe next time I'll be able to show practically. In the translabial ultrasound, we will put the gloves over the curvilinear probe and put it in between the two labia. And then we will be able to find out this is the uterus. See, you are seeing the fluid within the uterus. You are seeing the vagina distended with so much of blood particle. Every monthly, the patient, mothers will be coming. See, the patient, she is having lot of pain, cyclical pain during the months, but no menstruation. So at that time, it should come in our mind that it may be a case of imperforate hymen. This is again, you see, this one is full of the blood, and this vagina is so much distended with blood. And this is a picture of a patient with imperforate hymen, in which this one is a case of lot of blood, hematocolpus and hematometra. But the hematocolpus, hematometra may occur due to vaginal agenesis also. In case of vagina, this is a case of imperforate hymen, and in vaginal agenesis, there will be a dimple. In imperforate hymen, you will see a blue color bulging membrane. This is, as we know, the hymen is connecting membrane between vagina and the urogenital sinus, which gets during embryology, it disappears just before birth. In this case, it isn't. So we have to just give a cruciate incision in order to take out the menstrual blood. So another case of hypoplastic uterus. So many times mothers will be coming and saying that the other colleagues are having menarche, they have undergone menarche, but my child is not. So at that time, when we do that time, we have to do ultrasound with full bladder. See, in a transabdominal scan, the bladder is not much. We will not be able to see the uterus. See, this is the uterus. We are seeing a small uterus just posterior to urinary bladder. When the measurement of the in the transverse scan, if we see between two cornu, the measurement is less than 2 centimeter, and the length of this uterus is less than 5 centimeter from internal os to the fundus, less than 5 centimeter. That time we call it is a case of hypoplastic uterus. But if that time, even the clinical history has to be taken, because this type of uterus we may get in many other conditions, postmenopausal also we can get. So we have to take the history. The patient will not be having any menstruation. In that case, we will tell the case to be a hypoplastic uterus. So cornual, between two cornu, it will be less than 2 centimeter, and from the cervix to the fundus, it will be less than 5 centimeter. In that case, it is known as the. So many times we also, there are cases when even I have seen Turner syndrome and all, we cannot see. We write down a uterus-like structure, a hypoechoic structure, just you see behind the bladder, but you are seeing very good ovaries. So we just write down a hypoechoic uterus-like structure seen behind the posterior wall of the urinary bladder, measuring 80 millimeter. So that is it. Now, so many times we are seeing cases of prolapsed uterus. Now, as we know, prolapsed uterus is because the ligaments, the musculature, the lower, our perineal muscular body and all get means it laxed. Because of the laxity, the uterus starts coming out. When the uterus starts coming out, see, there is a low-lying uterus. What we write down? Low-lying uterus. First, the uterus becomes axial. Normally, the uterus is anteverted. See, this is anteverted. But first it becomes axial and then it becomes retrograde, or you should never write retrograde or retroflex unless you are very, very sure. You can write down retropositioned uterus. Retroposition uterus is a better term than retrograde or retroflex if we are confused for it. So see, this normally in the vagina, we see anterior vaginal wall, vaginal canal and the posterior vaginal wall, three line system in the vagina. But in case of prolapse of uterus, this three line in the vagina gets disappeared as the cervix has gone into the vagina, and this whole uterus, which should be seen as anteverted structure, has come down. So this is prolapse uterus. We should write down in the report as retroposition or low-lying uterus with descent, because it has gone a descent inside the. So now comes another important point is cesarean section scar defect. Nowadays we are having many cesarean sections. So when the cesarean section incidence increases, we also get pregnancy in the scar area. So this is the scar. This second figure, I am showing the second figure. You see the second figure, this transvaginal scan, this is cervix, this is uterus, and this is the endometrial lining. There is an anechoic area in the, and normally in case of post-cesarean, we see a hypoechoic line just above the internal os. We see a hypoechoic line. But when there is a defect, why defect occurs? Because maybe there was poor vascularization, so the scar has not fibrosed.
Please. Disturb nahi.
So we are getting scar defect, and then in this scar defect, you see properly if it is a case of post-menstrual phase, because in the post-menstrual phase, the blood gets collected in the scar area, and that time we can see the scar defect better. And see this scar, this is a full thickness cesarean section scars. Cesarean section pregnancy is now 1 in 2,000 pregnancy because of the increased rate of cesarean section. See, this is now they have healed, they have repaired the defect. So now it has become like this. So but we see a line. This is a cesarean section. Normally what we see, but this has healed. Now the repair has been done, and it is like this. This is a case of cesarean section scar pregnancy. It was a case of twin pregnancy. When they did the ultrasound, they found that 2 gestational sacs are lying in the scar area. Now, what are the criteria of cesarean section scar pregnancy? First is the endometrial cavity and the cervical cavity. This cervical cavity, this endometrial cavity, they are empty. You will not find any structure within any gestational sac within the endometrial cavity as well as the cervical cavity. Second point is you are finding some gestational sac-like structure in the anterior lower part of the corpus, just above the cervix. It is near the anterior portion, is near the posterior part of the urinary bladder. Only a very thin myometrial lining, maybe 2 to 3 millimeter lining you can see just between urinary bladder and the ectopic gestation. And when we put vascularity, the Doppler, we see lot of ring of fire appearance what we see in the ectopic. And there also increased vascularity in the posterior part of the bladder mucosa. So then only we can say it a case of cesarean section scar. So the endometrial and endocervical part is free of any gestation. The gestation sac is in the lower segment, just above the cervical internal os. it is the myometrium just between the posterior part of urinary bladder and the gestation sac is very, very thin, that is 2 to 3 millimeter. And when we put color Doppler, is lot of vascular supply, just a ring of fire around the ectopic gestation. Another ectopic gestation which is in the myometrium is near the interstitial pregnancy. Interstitial pregnancy is also within the myometrium area, but at that time the endometrium and interstitial pregnancy, there is an interstitial line sign which there is shows a myometrium, thin lining of myometrium between endometrium and the gestation sac in the interstitial area. So that is also very common. That is also very rare type of the myometrium pathology. Now let us come to the leiomyosarcoma. Leiomyosarcoma is one of the cancerous lesion in the case of uterus. The incidence is very, very low, 1 in 1,20,000 people. See, but we can easily find it out because it is irregular shape, inhomogeneous or heterogeneous, and it's a complex structure. What do you mean by complex structure? Consisting of solid elements as well as anechoic elements. See, these are the anechoic elements and these are the solid elements. So hyperechoic, hypoechoic and anechoic elements all are there within the leiomyosarcoma. As soon as we put color Doppler, because of neovascularization angiogenesis, lot of blood flow, increased velocity and low impedance blood flow you can see within the leiomyosarcoma areas. Now, this is a, see, in these days,
RI,
we are having,
RI will be lower than 5.
RI will be lower than 0.5, 0.3, 0.4, just like in
0.5,
ovarian. So it is very, very low and the velocity is very high. So that figure I am not able to show, but so this, in these days, we are having lot many cases of hysterectomy, maybe abdominal or vaginal. Hysterectomy, we get lot many cases. So many times patient comes that, and we see the vagina. This is vagina. Vagina is about 6 centimeter in length, plus minus 1 centimeter. And then we see the vaginal cuff. This is known as vaginal cuff. See, it should be hypoechoic, very, very thin. It should be hypoechoic and very, very thin. Unless it's a case of subtotal hysterectomy. In the subtotal hysterectomy, it is slightly thicker and nodular because of the remains of slight amount of the uterus. So in the total hysterectomy, it is very thin and hypoechoic. And this is the vagina. You may think this is normal, but this patient had come 14 days after hysterectomy with lot of fever and foul smelling discharge. So this is not a normal case of vagina. See, this is the anterior wall of vagina and this is the posterior wall of vagina. Posterior wall of vagina is this. What you are seeing in this is a tampoon. A longitudinal linear structure in the vagina is casting shadow, is tampoon. See, this is vaginal tampoon which the patient has not taken it out. So this has caused foul smelling discharge and the fever. Therefore, in cases of all operations, in all operation cases, so many times we have lot, like in cesarean section also, we get lot of bleeding in the abdominal cavity. And then we use Adgel. When we use Adgel, we should write down in our discharge certificate that Adgel of such and such size has been used in this area, because that Adgel will remain in the abdominal cavity for about 3 to 4 months. And that time, if we do the ultrasound, and we think it to be a case of some tetra or some gauze lying within the pouch of Douglas or some LIF or RIF. So we should always mention that we have used Adgel in the area, such and such area, such and such size, so that we will not get confused and we will not open the abdomen again. So see, this was so confusing. This was looking like a normal, but this was a hypoechoic. This is more thickened also. Otherwise, the normally it is only 3 to 4 millimeter thick, but this is looking quite thick, and there is a linear tampon within the vagina, causing lot of shadow behind it. So at the end of the session, what we studied in this session is all the Musa consensus statement, that is morphological, uterus, sonographic assessment, in which case we have to assess the total uterus in these headings. First is the measurement of uterus. We had studied D1, D2, D3 and cervical length, where D1 is the fundal length plus the uterine cavity length from internal os of cervix to the fundal tip of the uterine cavity. Second is the symmetry of the myometrial walls. Anterior wall and posterior wall symmetry has to be seen, because in cases of adenomyosis, they may differ. The anterior layer thickness may be much lesser than the posterior thickness depending upon the myometrial and adenomyosis, which part it is affected. Echogenicity, as we see in cases of the myoma, it may be hypoechoic, isoechoic or hyperechoic, depending upon how much of the comparison we are doing it with the surrounding tissue. Then comes myometrial lesions. So when we are doing myometrial lesions, remember that we have to introduce our probe in the longitudinal sagittal view. We have to do parasagittal spanning from left side, then right side we again come, then we have to do transfers, and then transfers from upper part to and lower part, from fundus to cervix. We have to see properly for any myometrial lesion, so that we don't just miss it, whether it is well defined or ill-defined, because well-defined myometrial lesion is a myoma and ill-defined myometrial lesion is adenomyosis. Then we have to write down about the number of lesions, where it is located, whether it is submucosal, subserous. See, there are 7 types of main 7 types of myoma, either submucous, 0, 1, 2, intramural, 3, 4, and subserous, 5, 6, 7. All these we have to differentiate properly and write down the maximal diameter. The diameter we have to write in 3 orthogonal planes, that is sagittal or longitudinal, antero-posterior, and the transverse diameter, as done in all SOL space occupying cases. In vascularity, we studied the vascularity of the myometrium and
That
also
means
the
two orthogonal planes, isn't it?
Madam, 3 orthogonal planes.
Orthogonal planes.
Always measurement is in the 3 orthogonal planes, that is antero-posterior, transverse, and the longitudinal diameter. The vascularity, we studied the normal vascularity of the myometrium by arcuate and radial arteries, and also the vascularity of different pathology like myoma. It was circumferential and intralesional. In case of adenomyosis, it was intralesional, and in case of AVM or RPOC also, we saw the enhanced myometrial vascularity.
I have a Ranjana madam, regarding measurement of the uterus, the hypoplastic uterus, it is D1 plus C is less than 5, no?
Less than
D1 plus C, that means ABC
madam,
together.
They say internal os to the fundus, it should be less than 5 centimeter from internal os to fundus. And the cornua, in between cornua, they have written 3 to 5 centimeter. I am saying 5 centimeter. It is written that in between 2 cornu, the distance has to be lesser than 2 centimeter, and the distance from internal os to fundus, it should be 3 to 5 centimeter. So then at the end, we see the mid-sagittal and the transverse view. But to confirm the pathology, if it is congenital anomaly, we have to do 3Ds. So at the end, again, we come to when we have to refer or not. So those patients in which we are uncertain about the diagnosis, for example, malignancy or about atypical myoma. See, there are many atypical myomas also. Even once we had got Wandering myoma. What do you mean by Wandering myoma? When the peduncle-related myoma getting torsion, and in the torsion phase, if it gets separated from the uterus and then it lies in the peritoneal cavity and starts taking parasitic blood supply from colon or from any other organ, then it is known as Wormstone, or it is parasitic. So at that time, it becomes difficult to find out what it is. So that time we can refer the case to the even broad ligament myoma or ectopic pregnancy. If we have any confusion, we should refer the case for the second opinion. So the key points in this case was MUSA, the myometrial pathology, finding out, that is morphological uterus sonographic assessment. By this only we should study the myometria. So if we are in doubt, refer the case for the second opinion. Thanks a lot.
It was a great presentation.
I think I have done some justice. I think I have done some justice to my topic. Madam, I like ultrasound so much that I can teach and teach and teach about ultrasound.
Enough justice. Enough justice.
Thank you, madam. Thank
you have done super justice.
Oh, thanks, sir.
Okay, can you take away your screen? Can you take out your screen?
Okay. Any doubts in the chat box? Stop sharing. Yes, those who are participating, any doubts, you can unmute and ask, or in the chat box. Put in the chat box questions, or unmute and ask.
Thank you,
Throw some light on choriocarcinoma. Yes, Ranjana madam, please tell us something about choriocarcinoma.
Madam, last time I had told about molar pregnancy, invasive mole. Molar pregnancy, we know it's a case of snowstorm appearance. Hypoechoic, some anechoic elements within the endometrial cavity, hypoechoic structure also, but in the endometrial cavity. When it goes into the myometrium, then we call it a case of invasive mole. And in the invasive mole, we have many blood in the, when you do the vascularity, many blood supply over there. But in choriocarcinoma, the myometrial thickness is very, very thin. It appears as the structure is just coming out from the serosa. So the myometrial thickness decreases a lot of vascularity within the choriocarcinoma structure. And then after investigation, we find out that the HCG is very, very high. So total full is covered with, just like leosarcoma, with the whole structure is covered with choriocarcinoma, but it's a case after pregnancy or abortion. So HCG test is very, very high, then only we can confirm it to be a case of choriocarcinoma.
There is another entity called placental site tumor.
Placental site tumor, madam.
HCG levels will be normal, or it will not be raised at all.
Madam, in placental site tumor, it is not like choriocarcinoma. It is just in the just after pregnancy.
Placental site tumor, what are the, it is dangerous and only treatment is hysterectomy. But prolactin HPR levels are raised, which is not done in the whole of this country.
Madam, should we show our video? Hello?
But you have stopped sharing. Oh.
Ranjana madam, I would like to say something about.
Oh, yes, Madam has 2 videos to show, which Sambit will be.
It is very important to discriminate retained products of conception, because sometimes we see only clots and blood when really you can go for conservative treatment, and therefore the color flow is very important, because then we can see the supply from myometrial artery to the endometrium, suggestive of retained product of conception. What is your take on this? Because many times, you know, people they have nothing left in terms of placental tissue, chorionic tissue. It could be only blood or some clots. So we suggest conservative. We don't actually do any intervention like DNC at that time, and only when we see RPOC is confirmed by blood flow, then only there is an indication for curettage.
Sir, but it's written, sir, that even in some cases of RPOC, we may not have blood in Doppler. We may not see blood supply.
There is avascular. There is a category of
RPOC also.
RPOC
present.
is also there.
So that time
blood,
also we have to do DNA, sir.
DNC. Okay, yeah, that's good idea. So this is one thing, and my point is why this Musa classification has been done. The reason is when I say it is a submucous, you know, less than 50% intramural, then I have exactly measured in those terms. And this is because the surgeons will have an advantage, or anybody who reads my report will, because of the terminology, they will have a very, very good idea as to what I am speaking. When I say location, when I say morphology, when I say blood supply, because then we are all speaking that same language. So it becomes very, very standardized way of expression. So there won't be any, there should not be, if done in a right way, and we have to learn this to do in a right way also. And this, these are very important, because many times they do hysteroscopy, removal of the fibroids, you know, which are very, we have to distinguish and diagnose very, very correctly. So these are the terminologies are very important, and also the standardization is very important.
And also in research, multi-center research studies, if I say hypoechoic, another one in the world should also say hypoechoic. Sir, another point in hysteroscopy that I was saying, in hysteroscopic resection, while doing hysteroscopic resection, we should always find out what is the free margin of the myoma. Free margin of the myoma. And one very important thing is hysteroscopic resection can only be done in 0 and 1 myoma type. See, these are the types of myoma. 0 is pedunculated and 1 is less than 50% in the myometrium. So only in 0 and 1 category we can do hysteroscopic resection, and at that time also the one who is doing sonology, ultrasound, should write down what is the free margin of the myoma within from the the distance between endometrium and the myoma base, to tell the so that the gynecologist, the surgeon who is doing the operation, will feel it easy.
Otherwise, there will be perforation of the uterus.
Otherwise, there will be perforation of the uterus.
And
so, yeah, this is something great. Yeah, great session. I
And
think we
the
are,
size
we
should
have,
not be more than 4 centimeters microscopically. Very, very dangerous.
right. So,
And
Yes.
just like in all cases, madam, if a fibroid is very enlarged, if the globally enlarged uterus more than 10 centimeter, we have to do transabdominal scan in place of transvaginal, because transvaginal scan is only seen when the uterus, anything is within 10 centimeter of our transvaginal growth. So in those cases also we cannot do transvaginal. We always, in all cases, first we should do
Yes, that's the rule.
transabdominal and then only we should go for transvaginal.
in developed countries where people have a lot of money, they go for MRI if the uterus is very large. You know, if the uterus is,
Congenital anomalies are
no,
not,
not only
MRI is the
congenital,
best.
not only congenital, even for mapping of fibroid,
Done first.
they say that when the uterus is more than 375 cc, the volume, at that time MRI is a better
Better
suitable.
option.
And when there are more than five fibroids,
More than 5 fibroids, MRI is better. That is written in the consensus statement.
statement also, yeah. Right. And I think everybody should download that. I think we have given it in our
Very, very good with that.
group. We have given it in our group. Please, those who have not downloaded, please download and print it, because this is a very, very useful document. And when it comes to ovaries and adnexal region, we are now going to share another statement which is related to IOTA group, means International Ovarian Tumor Analysis Group, where you can have a lot of definitions about descriptors. So I think we will share it in a day or two, maybe tomorrow. So please read these articles, so that what happens is the terminology is used, we are giving it beforehand, so that you will understand and just read it for a better understanding of these lectures actually. And I think Dr. Ranjana, your next topic is ovaries and adnexa. So we have completed the uterus and possibly
Endometrium and myometrium.
yeah.
Now,
So I think the next one is ovaries and adnexa, and then we are speaking about common adnexal pathologies, which is to be shared by Dr. Indira Palo of Berhampur. And the subsequent one, the last one, is very important. How to write the entire gynecological report, and that again is Indira Palo. And in two of our sessions, possibly, I think Dr. Madam Mala Sibal has agreed to be there. So let me ask her today. If she's not going to Thailand, maybe she is going to attend your session next Friday.
thank you. I'll be liking it, sir. She is very, very good, knowledgeable.
So it was a great presentation now. Today we have enjoyed. Yeah, actually, these two things are very important. I once missed a CS car pregnancy once. And yeah, that was one. And the second one was about RPOC, the CS car defect. I knew it very well. But sometimes, you know, what happens, I have one question. Let us say the entire myometrium is not there, you know, entire myometrium has been resected. There is a gap. And what happens when the endometrial tissue leaks into the peritoneum? Can it lead to endometriosis? In a cesarean scar defect, where the scar is present and the myometrium is not there at all, can endometrial tissues leak into the peritoneum or not?
Sir, excuse me, sir, I could not understand.
Look, what happens in a cesarean scar defect? What happens in a cesarean scar? There is a defect in the myometrium, isn't it? You have just cut it. So if the gap is very wide, you know, can endometrial glands leak into the gap and from there to the peritoneum?
Yes,
Is it
sir,
possible?
it can go. It can
So,
go. It can.
it
That's why the bladder endometriosis also can occur.
can occur. So this is one thing we have to keep in mind, that sometimes we have to look beyond that, not only to the CS scar, but we look beyond the scar, right?
Sir.
We
Beyond the
look
scar
beyond that.
also, we have to see everything. Sir, when we introduce our probe vaginally, we have to see the anterior wall for any endometriosis in the anterior, just posterior to bladder. We have to see the posterior wall for any endometriotic nodules in the posterior wall towards rectum. So we have to see
Girja,
everything.
yeah, Girja Shankar Das is driving and listening. I don't get focus on the road. Don't. Yeah, Girja Shankar Das.
Sir, sorry, sir.
Focus on the road. Focus on the road.
Yes, sir. Yes, sir.
Very dangerous. Don't do that.
ଆପଣ ଆଉ କାହାକୁ
Hope you have your seat
କହିଥାନ୍ତେ,
belt.
ଆପଣ ଶୁଣୁଥାନ୍ତେ।
Seat belt ବାନ୍ଧିଛନ୍ତି ତ?
Madam, ye, madam video ta houni ki madam?
Videota, Sambit, please show the video.
YouTube रे कर दो, YouTube रे बढ़िया बढ़िया सब जिनिस दउछि देखने को दे ये तो स्क्रीन शेयर कर दो।
Madam, just I am trying to get it that video if I can show it. Hello, are you able to see?
Yes, we are able to see.
So
Yes.
this is a case of we are introducing into the
Maximize it.
maximize. So I am introducing the probe. I have introduced it. Hello. Okay.
Full screen है नहीं?
So I have introduced the probe, and see this is this is the uterus. It's the anteverted uterus. This is the bladder, and this is the anterior part of the myoma. This is the posterior part of myoma. This is the endometrial cavity. See, this is the endocervical canal, and this is the endometrial cavity. There is a isoechoic myoma over here, which we will see a bit later by vascularity only. Because it is isoechoic myoma, it is very, very difficult to find out. I am doing parasagittally this side and that side. See, I am going parasagittally this side and that side. When I put vascularity over the colored Doppler, see, this is endometrial canal, and this one is the isoechoic myoma. So this one is the isoechoic.
Sambit, hello Sambit. In the chat box, they have requested to launch the post poll before people leave. There are only 68. From 81, it has dropped to 68. Please launch the post poll because that is an important part of the learning. Sambit, are you there? Hello.
Again, madam, sorry, ମୁଁ ମଝିରେ ଟିକେ ଅଲଗା କାମରେ ରହି ଯାଇଥିଲି. Madam, ମୁଁ launch कर ଦେଇଛି launch. Post poll.
When we put the color Doppler,
please answer the post poll.
And when we put the color Doppler, see, there is a circumferential vascularity over here. See, the circumferential vascularity, and now we are able to see the lesion so nicely. This is a myoma with a circumferential vascularity. Myoma posteriorly in the body of the uterus, and it is an intramural myoma with the circumferential vascularity. Next again. Next again.
Post poll question मागिलो, post poll का answer करनो.
Wait a second,
Please answer the post poll.
This is the second slide. Now you see the retropositioned uterus. This is anterior vaginal wall. This is posterior vaginal wall. This is endometrial cavity. This is the anterior layer of myoma. And now I am measuring as Musa consensus. As Musa consensus, the anterior, the fundal length. See, this is the fundal length. This one. Then I am measuring the cavity length from fundal tip till the internal os, and then the separate is the cervical length. Again, I will measure the anterior-posterior, anterior-posterior. Then I do transverse. To make it transverse, it is slightly difficult, but by doing every day, you will be able to do it. And this is a transverse. This is the ovary. Only one, that patient had only one ovary because the right ovary and appendix was already removed. See, you see some myometrial cyst over here. These are the myometrial cyst. We are not able to see properly. Just I will show in the posterior part. See, this is the myometrial cyst. This is the myometrial cyst. 1, 2, 3, 4, all are myometrial cyst. And when we give vascularity, there is all intralesional vascularity. See, so many intralesional. It is not circumferential. It is intralesional vascularity. So this is a case of adenomyosis, just near endometrium, but posteriorly, this is a posterior part of uterus, and this is the anterior part of the uterus. Sorry.
Thank you very much.
I think
Thank you.
for adenomyosis, two features. One is the fan-shaped shadowing and myometrial cyst. If these two things are seen, you have a very good sensitivity and specificity of detecting adenomyosis. Fan-shaped striation and myometrial cysts.
And heterogeneous, sir. I think
Right.
heterogeneous is also very important.
Right.
Because in
because-
case of
There is
myoma,
another point for discussion which should be told to everybody is the fan shape, this Venetian blinds or this rain infrared is also seen in myometrial in myoma. So how do you
Myoma.
differentiate those same shadowing? Myoma also has attenuating shadows similar to adenomyosis. How will you differentiate the two?
Then because fibroid normally are very well encapsulated, there will be a very distinct boundary line between fibroid and the adjoining healthy myometrium. In case of adenomyosis, this is obliterated. The junction, the boundary between the mass and the myometrium is not very clearly seen. Actually, not seen at all. Actually.
When there is
Secondly,
focal
the
cystic
myometrial
adenomyosis,
cyst.
see, listen,
Secondly,
there is
myometrial cyst.
an entity
Madam.
called, please, there is an entity called focal cystic adenomyosis. In
Yes.
that case, differentiation is little difficult because it will be also circumscribed. Focal cystic adenomyosis.
Yeah, that is true. That is called adenomyoma. In a very, it's a small patch of myometrium. It is not a very large. And also adenomyosis, the symptoms actually will depend upon the extent of the disease. Many women, they complain of pain, but then if the lesion is very less, they don't have a lot of symptoms.
But in adenomyoma also, sir, myometrial cyst will be there in the endomyome because it is all, see, in menstruation, there will be hemorrhage clot, Swiss cheese pattern. There will be hemorrhage as well as clots will be there just cyclically post-menstrually. So in adenomyoma also, we have the features of myometrial cyst and hypoechoic inhomogeneous structure.
Adenomyoma is the same thing except that it is a focal lesion. It is in a small focal lesion. Yeah. Same pathology.
And intralesional pathology, vascularity in comparison to the myoma where there is a circumferential, more circumferential.
Right.
Before you leave, please answer the post poll and listen to all the questions that will be answered. Don't leave before that.
Thanks.
I think with the clarity of the presentation, everybody should answer correctly all the questions.
Madam,
They
only
should-
that D1 was a difficult question.
No,
Now it
D1
is easy.
D1
Now it is
was
easy.
quite difficult. And type 1 of submucous, that is also, I think.
See why question number 1 everybody is making mistake. It was
Yeah,
very
because
clearly
number
discussed.
1 is, they are thinking number 0 is number 1. I think because of that.
Pedunculated is 0.
Pedunculated
1 is
zero.
less than 50%. It is not intramural. Why some people have answered intramural? Intramural is wrong. That means these people have joined late. They have not listened to the discussion.
Madam, many of them are
Yes.
actually in the hospital. They are actually seeing patients. It is very
Yes,
difficult
yes.
for them. Yeah,
That
many
is
of
the
them are
limitation, yes.
they are working
Yes,
actually.
sir. In DHH and all, yesterday
that-
evening,
No,
madam, I
no.
came.
Yes, it is for them that we are discussing the post-poll questions one by one. So please stay back. If you have missed the pre-poll and the discussion, these things will be clarified now by Dr. Hasmukh sir.
Madam, amount of work we are doing is yesterday evening when I came, there were 12 cesarean section. I must have done 8, another one 4. Today morning there were 7 cesarean section. So, and now
Why
the
so?
patients must be there in the labor room for triaging has to be done. So lot of work, overload in.
Yeah, hats off to you. In spite of that, such a lovely presentation you have made. Hats
Madam,
off.
ultrasound I like
Really?
a lot, madam.
Really, yes. It is
Because
because
now
we
we
like
can-
our work.
she is doing every day.
You
She
are
is
the
doing every
unsung
day.
heroes. You are the unsung heroes.
Thank you, madam. Thank you.
Dr. Ranjana is doing
All of you,
actually
those
ultrasound
even
every day.
participants, even all the participants, hats off to you. In spite of your heavy work, and it is because of that we arrange a program for you, because you miss out everywhere, can't go for trainings. That is why Hasmukh sir and all of us have put our foot down so that you will be given the training online. People were very skeptic. How can people learn online in ultrasound? But don't worry, we will also say
I would request my friends to put it in a chat box how far this training has been helpful to you. Put it in the chat box how far this type of virtual training has been helpful to you.
Sir, my Mayurbhanj doctors were really praising all of us that we are doing a great job. It's very, very good. Everyone was liking it, sir.
and private practitioners are a little jealous. Because
For private practitioner, we have to charge money. It is not to be free. We all paid money to learn ultrasound, and we are
yes,
paying
yes,
it.
yes, we will charge money.
We are
They
paying.
will have to pay.
we are paying every day. You know, so many conferences we are attending every day. We have to.
Yeah.
So now we can discuss the post-poll questions, sir.
Sir.
Okay, 72% have answered. So who Sanjay is requesting, no?
And Dr. Satyajit.
Sanjay always request.
Dr. Satyajit. Okay.
So
Shall we discuss? Okay.
Yeah,
Because
thank
they
you
might
again.
leave. Number
Thank you
1.
again. I can't see the response here. I cannot see how much is the. I cannot see the post poll. I can see only the questions here.
Yes,
I
Sanjay.
can.
Thank you. Very, very useful. Please convey this to the DFW. He was very skeptic. How can ultrasound be taught online? we had a lot of diplomacy to get this program through.
मैडम मु कहि देबी सब आंसर करिवे
हाँ सर
Okay.
Question
Now,
number 1.
question number
1%
1.
have answered.
Yeah, B is the right answer. This was a very clear cut, good slide where Dr. Ranjana had described it. Less than 50% intramural. That means most of it is in the towards endometrium. This is most of them are towards endometrium. Therefore, these are very easy for the hysteroscopic removal for the surgeon. And B is the right response, intramural. This less than 50% intramural. This location is very important, and I think all should read that Musa statement where it is very vividly and very clearly described all the terms and definitions actually. So I cannot see how many people have responded right. I cannot see here in poll. Can I see them?
So just
Okay. Number two is echogenicity of myoma is mostly. Question is mostly. It can be anything, but most of the myomas are hypoechoic in nature, and that is the distinguishing point from other pathologies. Like it could be, this is very distinct, and myomas are generally very well encapsulated. There will be a very clear zone between the healthy myometrium and the fibroid tissue. So this is a point of distinction, and hypoechoic, that is the right response is B.
No, all of the above, because they can be anechoic, they can be complex. All of the above is the right answer.
No, it is we are talking mostly. We are talking percentage wise. Mostly, what is the thing?
Mostly is hypoechoic.
Hypoechoic, mostly. It can be all of the above, but
Sir,
mostly
all of
generally.
the above, if there is degeneration, then it will be cystic degeneration, complex. But
Anechoic.
mostly it is hypoechoic.
Commonly it is hypoechoic. Now, full
27% have answered correctly.
Number three is full form of Musa group. This is repeatedly, I think madam has repeatedly told us, morphological uterus sonographic assessment. D is the right answer. D is the right answer.
93% have answered correctly.
Right. And question number 4, according to Musa group, corpus length is depicted. Now just look at the question. It is, we are asking corpus, we are not asking cervix. We are asking corpus, means only the fundal, I mean the body of the uterus we are saying. Therefore, D1 is the right answer, where cervix is not included. So according to Musa group, corpus, and this is mostly done because of we want to rule out adenomyosis, and therefore we need to assess the volume of the body of the uterus. So therefore D1 is the right response.
So Ranjana madam की जय.
नहीं मैडम वो तो बता नहीं पाई.
Ranjana madam की जय. Okay.
Yeah. Question number 5. According to Musa, all of these myometrial pathologies are rare except. So out of these 4, I think adenomyosis is the right response, because we will see congenital anomalies in a very less percentage. Calcification we don't see very often. Enhanced myometrial vascularity also we don't see very often. We see adenomyosis is the second largest group after fibroid, or so that's the right answer is C. Now number 6 is well defined round hypoechoic lesion in uterus is normally it is fibroma, it is myoma. So myoma is B is the right response. Number 7, adenomyosis can be detected in ultrasound when the uterus is enlarged, when it is globular with myometrial cyst, it has a fan-shaped shadowing. All of the above is the right answer. And in cases of adenomyosis,
And spectacularly, everybody has answered correctly this one, 100%.
so yeah, very typical. I think in one of the study, Lil Valentin has said that myometrial cyst and fan-shaped shadowing, these two features has been very, very sensitive and specific. I think this slide also I have given to Dr. Ranjana madam, and where she has described, Lil Valentin has described these two features, fan-shaped shadowing and globular with myometrial cyst. And in cases of adenomyosis, always there will be hypertrophy of the myocytes where the endometrial glands have invaded. The myocytes, they get enlarged, and therefore, if it is, and mostly it is in the posterior aspect of the uterus because of the, they say this is one of the thinking that they say it is more common in posterior wall of the uterus because of gravitational effect. Because of the, and therefore the posterior wall will be very, very thick. If you measure the distance from the endometrium to the anterior wall and the distance from endometrium to the posterior wall, we give separately. There was a very distinct, clear slide also, and the posterior wall thickening or anterior wall thickening, both are possible, but mostly it is due to gravitational effect. Posterior wall is often involved, they say. Question number 8. I think this was also very beautifully shown by madam, and also she described how the arteriosclerosis with calcium deposition occurs. And we all know, I mean, as physicians, we all know that whenever a lesion is, there is a whenever there is a lesion with calcification, it is less likely to be malignant. Calcification is a sign of benign pathology. And Dr. Ranjana, you agree with me?
Yes, sir. Yes, sir.
Yeah. So arteriosclerosis.
And calcification occurs at the end stage of degenerations.
Right. So this C is the right response.
80% have answered correctly.
Now, question number 9. Myometrial vascularity in retained product of conception is. We always see enhanced vascularity. We will see more vessels. Either it is a multi vessel or a single vessel. Normally, single vessel we are supposed to see, but sometimes when the endometrium is widespread, then we see multiple vessels also. So enhanced myometrial vascularity is the right response. B is the right response for question number 9. Now, color score, this is often we will discuss. We will come back again to this color score, and this is the same principle. We will also come when we are looking at ovaries and the adnexa and the tumors. Again, same scoring. Please remember, when there is no color, it is 0. When there is minimal, it is 1. When it is
1, sir. 1, 2, 3.
No
medium.
color means 1. No color is 1.
No color means 1. And minimal color is 2. Moderate is 3. And abundant is 4. Yeah. So correct answer is moderate color is defined as 3.
Very good. 86% have answered. Fantastic. Hats off to Team Odisha.
Thank you. Looking for a madam.
So Dr. Ranjana, thank you so much. Thank you so much for
Thank you, sir. Sir, you have helped me a lot also.
So accelerated reduction in maternal mortality. ତମ କାନ୍ଧ ଉପରେ ଅଛି। ଆମର great specialist
We are doing a lot, madam. We have already had anemia Mukta Bharat training.
Brigadier. So together we will definitely reduce maternal mortality in our state. नहीं?
Thank
Draupadi
you.
Murmu हमारा president है ले, So
मयूरभंज रू रंजना
सेटा
मैडम
भी आम पूरा ये
to Draupadi Murmu, and in that honor ओडिशा रू प्रेसिडेंट हेले माने ओडिशा रो मैटरनल मोर्टालिटी भी सबटू मिनिमम करके हमें देखेबे सबुडी ट्राइबल नॉन ट्राइबल एरिया सबुडी हमें देखेबे एंड यू आर द हीरोज
Yes.
हला
बहुत
Thank you
लोग
very
एक्चुअली बहुत लोग पार्टी लाइन रू अलगा क्रॉस वोटिंग करिसनी
हाँ।
मुर्मू फेवर रे
डॉक्टर नईम को पुआ मुकिम हमर कटक रो जो बारबाटी रो एमएलए से कांग्रेस रो से कहले
हाँ।
माटी आगो तापरे पार्टी बढ़िया
I think
डॉक्टर
lot of people have
फाइन जेंटलमैन हां
even if I would have been there, I would also do the same actually. Yeah.
yes
And
he
I
was
belong to
enough
that
and
area. I am
courageous
very
enough
proud
to do it.
also, madam.
yes you are at Mayurbhanj no
Mayurbhanj.
Rairangpur.
Mayurbhanj. Mayurbhanj.
I have been to Rairangpur. There Pramod Sahu is there, our specialist. Has he joined? Pramod Sahu. He came for ultrasound training to SCB. He was at Rairangpur when I went for inspection in initial phase when I was going
yeah.
on tours.
And thank you
Okay.
all the friends you have appreciated this sort of training in the chat box. Yeah, it is a thank you that you have appreciated our efforts.
And we are
And
all
thank you.
enjoying ourselves, isn't it?
Right.
We are learning and enjoying. So if we enjoy, then we really.
I will feel sad when it is over. I will feel sad when it is over. We are just three
No, it is
presentations.
the beginning. Now
We are just-
you are seeing them on the screen. Now you will go in person to them.
Yeah, that's right. So we are just 3 presentations away from virtual end. Then we have a lot of work in the field actually. Yeah.
I think they should all register for CUSP.
CUSP
which
is very useful. CUSP.
CUSP.
There is one CUSP. आ गोटे IMA तरफ रो हमारो गोटे हेबो ओडिसा रे अक्टोबर रे
That
अछि
October.
IMA Rajat has done. And Rajat, I was saying to Rajat that Rajat is a very famous person in the group of radiologists, you know. So what happened is he managed to call not 1 but 6 of them. 6 of them for that event.
So but he must have a big hall for that. No? So many participants, where will they sit?
Mayfair, madam. I think it's there in Mayfair on, and it's very low amount also, only 500 or something like that, madam.
500 rupees. Yeah.
Mayfair Convention Hall, eh? Mayfair Convention.
Yeah. Convention Hall.
Mayfair.
And we will all meet over there.
Sure. October. There are a lot of events now actually. All are attending on site. And
Now, anyone attending AFSCMB, please tell me also.
Hyderabad.
I wanted a companion.
Yeah, but you need a woman partner actually. You need a woman partner.
Woman partner, that twin sharing.
I had suggested some name to you. I don't know.
Nice, sir, but no one is going.
No, but you why don't you ask the organizer to
I had
tell
already
them?
asked.
Yeah, to tell them that.
They told in the end they will show.
Right. They will adjust you somewhere actually. Right.
Thank you, sir.
Thank you so much. Yeah, it was a great effort, and also your talk was very useful. Even
one big thing is she repeats. Repetition is very important for learning, and that's a wonderful thing with Ranjana madam. She keeps on repeating till everybody understands. So thank you very much.
Thank you.
Let's call it a day.
Thanks a lot.
Namaskar.
Okay.
Thank you.
Bye, everybody. Till next Friday.
Yeah.
Yeah, madam.
Shall we leave? Bye. Thank you very much for your feedback. Ranjana madam is in OT dress. Okay, goodbye everybody.
तो देखिला ये जो ये म सुन ना ये तो तुम रखिस तो हां देखो से मत किछि कोन हां मन से तो आगे कोन करियो ना ले ऐसे किछि कहू से मतलब तो देखा हम बाहरियो किछि कहू से वेंटिलेटर आनी से केबे तो देछि ताको दर्शक करिजे हां किछि कहू